Aaron, I see you've unmuted. Can you hear us still? We weren't able to hear you, Aaron, if you were trying to say something. Happy to do an audio check with any other board members while we wait for our court reporter.
Good morning.
Good morning, Tom.
Good morning, Kristen, I'm here. I can hear you on my phone, but I cannot hear you on the computer. It's not coming through. Are you guys also doing video today on the team?
Yes.
So everybody is present on video, and I don't see anybody.
The only thing I can suggest now is to either leave the meeting and try to come back on.
Okay.
Morning, Susan. Can you hear me okay?
Yes, I can. There is a little bit of an echo, so maybe somebody's volume needs to be muted.
Looks like it could be two people on the phone, maybe.
Yeah.
Okay. All right, if there's anyone on the phone or observing the hearing who's not muted, could you please mute? All right, I'll order the Green Mountain Care Board's hearing of 13, and then in the afternoon of here. So,
Oh, and you are going a little in and out. You might
minutes.
want to turn your camera off. Your connection is not good.
Sorry, let me try that. Is that better?
Yes.
I apologize. So one programming note, Member Holmes had a conflict today and won't attend today's hearing. She'll watch the hearing later, but she's unable to attend. I think it's one of the few in her 10-year illustrious career at the board that she's ever missed. But today she won't be able to make it. And I am going to step out for the Elidade hearing. I'll abstain on that one. But before we get to the presentations, I move to approve the minutes from November 6, 2024.
Second.
And all those in favor of approval, say aye.
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 Aye. And the minutes are approved by 4 members. I'll turn to Michelle Sawyer and Mark Hengsler for the overview of the Medicare only ACO budgets.
Great, thank you, Chair Foster. Let me get my slides going. Are folks able to see my screen okay?
Yes.
Beautiful. All right, we are here this morning to kick off ACO season here at the board with the budget hearing for 3 Medicare-only ACOs, Aledade, Lore, and Vitalize. So we're just starting off with a quick staff intro, and then we will hear from all 3 ACOs, one after the other, as they present their FY25 budget. We'll have time for staff and board questions, questions from the healthcare advocate, if there are any, and take public comment. I wanted to take the time to ground us in what we are looking at today as far as ACO regulatory processes. It really depends on what type of ACO we're talking about. So on the left, we have ACOs that accept payments from Medicaid or commercial insurance. And on the right, we have ACOs that accept payments only from Medicare. And these are the ACOs that we're talking about today. These are all 3 of them are Medicare Shared Savings Program ACOs, and they only contract with Medicare. So you can see from this flow chart on the right that there is not certification required for these types of ACOs, but there is a budget review required every year that they operate in Vermont. And then the next level goes to how many lives they have in Vermont, how many Vermonters are attributed to the ACO. And the threshold is 10,000 lives. And in the case of these 3 ACOs, each one of them individually has fewer than 10,000 lives present in Vermont. And so that means that the standards and processes that the board follows really depend on what the board determines is appropriate. And lastly, I'll just note that there is a Medicare only ACO guidance. The budget guidance is reviewed and approved annually by the board, and we took care of that earlier this spring. I'm going to pass it over to Mark Hengsler, our staff attorney, to walk us through the budget review process.
Hey, good morning, everybody. Oops. Can you hear me? I'm sorry to interrupt. I'm the court reporter this morning.
Hi.
Morning, Aaron.
Hi, good morning. I just want to make sure and verify. I'm sorry, I was having some audio at first. So I want to make sure that we are not on the record at this point. Or were you under the understanding that, I'm sorry.
Yeah, we can be on the record. If not, the most important part to be on the record is actually the hearing with the ACOs. Preferably, we
Okay.
can be on the record now, though.
You want to go ahead and be on the record. Okay, and then I'll just note the
That's
time
fine.
that we're on the record at 9:08 a.m.
Sorry about that, Aaron. Thank you.
No, it's okay. Thank you.
All right, good morning, everybody. I'm going to walk us through 3 slides to give a legal overview of what we're doing today. I'll start with the baseline for how the statute and rule direct the board to review the budgets of Medicare-only ACOs. Starting point is at Rule 5.404A of the GMCB rules, which provides that an ACO has the burden of justifying its proposed budget to the board. However, in deciding whether to approve or modify the proposed budget of an ACO that's projected to have fewer than 10,000 attributed lives, which, as Michelle stated earlier, is all 3 of the ACOs that the board is looking at today, the board takes into consideration the following. 1, any benchmarks established under Section 5.402 of GMCB Rule 5. 2, criteria listed at 18 VSA 9382B1 that the board deems appropriate to the ACO's size and scope. I'm going to loop back around to that one in about a minute. 3, the elements of the ACO's payer-specific programs and any applicable requirements of 18 VSA 9551
Hey,
for
Mark,
the Vermont
sorry, I'm sorry.
payer. Yeah.
Let me interrupt. Who's ever 802-338-7438, please mute your phone. We can hear you. And could you please just mute? 7438, please. Thank you.
All righty. And for any other issues at the discretion of the board. So feel free to hop to the next slide, Michelle. When the board is looking at the budget of an ACO with more than 10,000 lives, the statutory criteria for budget review are all applicable. However, as I showed in the last slide, the board makes a determination about what criteria are appropriate for ACOs that have less than 10,000 lives. So with that in mind, staff have some recommendations for the criteria the board might want to consider for these ACOs. These criteria are not changed from last year. This is what staff presented last year. But I'm going to go ahead and read through these just to ground us in the items that staff believe are relevant for reviewing budgets for these ACOs. And these are all from 18 VSA 9382B1. That section of the statute has the big list of everything that's relevant for an ACO with more than 10,000. These are the select items within that list that staff believe are relevant for the ACOs we're looking at today. So first, information regarding utilization of the healthcare services delivered by healthcare providers participating in the ACO and the effects of care models on appropriate utilization, including the provision of innovative services. 2, the character, competence, fiscal responsibility, and soundness of the ACO and its principles. 3, any reports from professional review organizations. 4, the ACO's efforts to prevent duplication of high-quality services being provided efficiently and effectively by existing community-based providers in the same geographic area, as well as its integration of efforts with the Blueprint for Health and its regional care collaboratives. Go ahead and hop to the next one, please. Thanks. 4, public comment on all aspects of the ACO's costs and use and on the ACO's proposed budget. 5, information gathered from meetings with the ACO to review and discuss its proposed budget for the forthcoming fiscal year. 6, information on the ACO's administrative costs as defined by the board. 7, the extent to which the ACO makes its costs transparent and easy to understand so that patients are aware of the costs of the healthcare services they receive. And finally, the extent to which the ACO provides resources to primary care practices to ensure that care coordination and community services, such as mental health and substance use disorder counseling, that are provided by community health teams are available to patients without imposing unreasonable burdens on primary care providers or on ACO member organizations. Michelle, I'm going to turn it back to you, I think, for the last slide.
Great. Thanks, Mark. So this is just a quick timeline. So we received most of the ACO budget submissions on October 1st. Vitalize did request an extension, so we allowed them to submit their budget on November 1st. And then today, the 13th, we're here for all of those hearings. And next Wednesday, we will have a staff analysis and a potential vote on all 3 Medicare-only ACO budgets. Public comment is welcome. The public can submit comments by Monday, November 18th, to be considered ahead of the staff analysis presentation and the potential vote. And with that, I will hand it back to you, Chair Foster.
Thank you very much. Is my audio working okay, Erin or Susan?
Sounds good to me.
Yes, it is.
Great,
Thank you.
Great. Thanks. And are the folks from Lore Health here?
Yes, good morning, Chairman Foster. I'm Mark Breesacker from Lore Health, and Mark Atala also has joined.
Yes, good morning, and also
Mr. Breesacker, Mr. Cullen. Thank you. Thank you for being here. I'll have our counsel swear you in, and I assume you're ready and prepared for your presentation.
We are, thank you.
Great. All right, Mr. Henksler, would you mind swearing in the witnesses? And then Mr. Breisaker, you can just take it over from there.
Thank you.
Yep. Apologies. Just give me one moment to pull up the language, which I should have done ahead of time and didn't do. So just grabbing it right now. All right. For those who are going to be testifying on behalf of Lore, please go ahead and raise your right hand. Do you solemnly swear that the evidence you shall give relative to the cause now under consideration shall be the whole truth and nothing but the truth, so help you God?
I do.
I do.
All right, thank you. You are sworn in.
All right. Well, thank you all very much. We'll start with an introduction about Lore, discuss a little bit on 2023 results, and then hand it to Mr. Atala for a discussion of the 2025 year budget. We are as was shared earlier, a Medicare Shared Savings Program, ACO. We're a multi-partner, multi-state ACO. We have one partner in Vermont, and we operate in 4 other states as well. We are different from many ACOs in that our main focus is partnering with federally qualified health centers. This gives us a unique population, which of course includes people on Medicare when they become eligible at age 65, but also a significant number of people who are dually eligible, and as well as people on disabilities. And we work with CMS and others, and really the purpose of the whole budget is to do the things where we can coordinate care, improve that quality of care, and meet the objectives of the program. In 2023, that was our first year, and I'm going to spend a little bit of time just talking about our quality and program work during that year. It was a baseline year for us, and we were successful in collecting and coordinating the submission of quality performance data across the multiple EHRs and multiple partners in the national ACO. We came up with our baselines of performance in diabetes, hypertension, and the process of care, identification and process of care for depression. And the results of those data show that we do have, first of all, we have very committed clinical partners who are deeply engaged in their performance. And these data, just one other additional note, are for all their patients, not only their ACO patients, but for all their patients that they serve. We identified opportunities to improve in diabetes care, specifically in sending out reminders to help people come in for their visits and have the status of their diabetes management monitored. The same was true also for hypertension. Performing in diabetes and hypertension showed that really there was about 30% of our total patients that would benefit from additional focus around care coordination and supporting them in their self-care of those conditions. And on the depression screening, we are working with our partners mainly in the area of helping them configure their electronic health records so that they can capture the care that they are providing in a way that then can be reflected in our results. The main focus of all of this is of our other program with patients is just supporting patients themselves in what they can do on an everyday basis to take small steps in improving self-care, feel better about how they're getting through life, and have the energy and the empowerment to be taking control in small ways of their chronic medical conditions and their life overall. Maybe the last point I wanted to share is another report that we share with our partners is an opioid use report that CMS provides to us. And this is a report that just informs practices of their patients who are on high doses of opioids and who are getting prescriptions from multiple providers. And we provide this report to our partners who then begin the outreach and the outreach so that they can help that person begin to take small steps to get that also under control, ideally getting to a single prescriber and then beginning to work on the actual issues in play here so that overall dose can be reduced and the risk of overdose can also be reduced. And it's a small thing that we are doing to, as part of the broader policy approach in Vermont to address this really challenging problem. So with that background, Mark Atala, I'm going to hand it over to you to go over the 2025 year budget.
Sure. Thanks, Mark. Michelle, do you have slides that you will present, or do you want us to share, or we're happy just to talk through our budget?
I can, if you give me a moment, I can find your slides, but I was not prepared to present them.
That's okay. Just wanted to check process. We can share if we're allowed to.
Thank you.
Can you see my screen?
Yes.
Super. So as part of our, and it's good to be with the board again. So we have financial results from 2023, and they were really neutral at the ACO level. When we break that out in terms of expenditures from Vermont, we found this is a truncated number, meaning the $9,500 per year removes the 99th percentile of cost. And so this is our set of results, I think, consistent with what we were expecting in terms of truncation. I think overall results, you'll see some projection changes for 2024 as well as 25 based on final year results from CMS, which were significantly just delayed this year relative to previous years based on a number of things that has happened with CMS. In terms of deltas, we saw our final attribution decline from our projection for 2023, which has also led us to revise our 2024 and 2025 budget. And with that, consistent with that number month reduction, we're presenting a truncated expenditure number now in terms of beneficiary expenditures. So that's important because it's not a total expenditure, and so we're happy to answer any questions there and how you ask us to present, because in terms of shared savings or losses, it's based off of a truncation, and so for purposes here, we chose to make that consistent. Our projected savings for 2024 and then also 2025, we've revised based on 2023 performance, and you have that budget proposal as well. Obviously we hope to perform better in 2024 and 2025, but I think we're realistic in terms of what can be done, and this is really a process that we're committed to in terms of improving care and building foundations to deliver savings over the long term. So with that, I'm happy to answer questions from the board and the public.
I'll start with staff, if staff has any questions.
Thank you. We only had one question, and that was whether you are able to share the Vermont specific providers performance as far as shared savings or losses is concerned. And if you're not able to do so in a public setting, submitting the answer in writing is perfectly fine.
We can certainly submit. I mean, I think you have our expenditures. I think benchmarking is such a complicated process because you're reviewing, a number of factors around risk ratio, et cetera, that, we wouldn't, I think segmenting out Vermont separate from CMS, which CMS doesn't provide us Vermont specific data, really wouldn't be precise. And I don't know that it would further, we don't see, substantial differences between Vermont and our overall performance. So I think from a specific benchmarking perspective, we don't, we're not expecting that big of a difference. But expenditures certainly, and that's what you have, and that's what we've been able to segment. I think benchmarking is a counterfactual, and it's just something that CMS doesn't provide us. They provide us ACO wide data, and so I think it would be hard for us to produce true risk ratios and true trend factors specific to Vermont only. For those reasons, we don't have catheter fraud, et cetera. We don't have access to that type of analytics or data that CMS runs over a very long period. But Michelle, hopefully that helps at least.
Sure. Thank you very much. That's all, Chair Foster.
Thank you. And I'll turn to the other board members for any questions they may have.
I can start with one quick question. So I was looking at just eyeballing the target PBPY of 9524. That's your all of the ACO, it's all states combined, your national target?
That's actual expenditures truncated in Vermont for 23.
Expenditures or I guess I was
expenditures. So we can see expenditures in 23. So not even a target. It was actual truncation for us. So and then we use that really for trending based on what we can see for 2024 so far, and then trending that forward to 2025. But that is only Vermont specific. Tell me if that makes sense. So we looked at essentially who was attributed to us in 23 and what their truncated expenditures were, and that's the 9524.
And then just maybe so you can help me understand a little better. Sure. When you're trying to figure out shared savings, is it based on that target?
Our shared savings is not even so again that is a true expenditure. So like that's what the target is set across the ACO, and so what CMS is essentially doing is they're taking beneficiaries. They have historical expenditures of those beneficiaries, and we have like us and other ACOs here, we have a historical benchmark. For us, because our performance year started in 23, that historical benchmark is weighted 60% 22, 30% 21, and 10% 2020. And so what CMS does is they'll give us that number, and then they trend it forward, and then also risk ratio adjust it. So they're looking at our population, and they're doing it by 3 or by 4 different types of populations. So ESRD, disabled, patients with both Medicare and Medicaid, and then patients with just Medicare. There's risk caps associated with that. So if the risk score in one area goes up by more than 3%, that's capped. If the risk score goes down, there's no actual downside cap. And so what's happening is you're taking your initial number, your initial benchmark, which is your target. And again, for us, that's an ACO-wide target, so it's not Vermont specific. And then you're having to perform both risk ratio adjustments and then also a trend factor adjustment. There's other parts in this, CMS had this issue this year. There was some fraud that they removed from expenditures. If there's other payments around Dish, GME. They remove those from claim. I mean, there's a very large process that's had tens of millions of dollars applied to it to try to come up with what is a good counterfactual. And that's the target we get. But that target is for us is done at an ACO wide level, not at a patient or Vermont specific level. And so when we show the 95-24, what that's showing is here was our expenditures after applying essentially a stop loss of truncation of national expenditures at the 99th percentile. So not Vermont specific again, but they apply that to remove outlier claims essentially, so that benchmarks are slightly closer to an expected result. That was a lot of words, but does that help?
I think it was helpful for me. Yes. Can I just ask you one question about the fraud? Are you talking about
Sure.
this catheter fraud issue
Yeah.
that was? And my understanding of that issue, it was not involving any patients within Vermont, but there were some Vermont patients outside of Vermont that there was apparently fraudulent catheter claims towards. Is that your understanding of it?
Yeah, our understanding is not, it's not. It was around 3 billion plus of expenditures that were identified. It seems to have been random beneficiaries. If maybe if Vermont was not chosen as part of that list, that's good. And I think what it showed in 2023 was people were seeing expenditures that weren't there, and so if in that case if an ACO either showed better projections than they were expecting, it could be because others in the overall population, their costs were going up at a faster rate than areas that the catheter fraud wasn't happening. And so I think our understanding was it resulted in like a 0.5% or so reduction in savings for ACOs, but that's at a broad national level, not Vermont specific. But that's our understanding of the catheter fraud piece.
Thank you.
Sure.
Hi, this is Robin. I have a couple of questions. In your submission, and I think we might have talked about this a little bit last year, you had mentioned that you provide beneficiaries with in-kind incentives, and I wondered if you could give us some examples of how beneficiaries might benefit from those type of incentives. Like what kind of incentives are they?
Sure. I'm happy to start. So I think to clarify one comment that was made earlier was around ACO cost to beneficiaries or ACO costs in general. There aren't costs for beneficiaries at least in terms of the shared savings program, and I'm not aware of other costs in Medicare only ACOs that patients would ever bear. So our view on in-kind incentives is where allowable under the regulations and law. If there's areas where beneficiaries can improve their health that are not covered by Medicare, and that for us makes sense to help patients with, and then our core example probably is food, so healthy food. Then that's an area that we try to fill gaps in, and so that member lunch, that would be our core in-kind incentive. That's not something covered by Medicare today.
That's interesting. So how do you do that? Do you give them a grocery voucher, or like, how do you provide that as an incentive? Farmers market?
Yeah, they receive a card that's locked down to only grocery stores. And so that's how we were administrating it, similar to others. So we hope it works at farmers markets and stuff.
Great, thank you. I think I just had one or two other questions. Take a quick look. So in your submission, you talked about partnering with local community-based organizations to help patients access care. And I know your network in Vermont is very small. Who are you partnering in terms of local community-based organizations outside of your provider network in Vermont?
Yeah, I'll take that one, Robin. We work with Senior Solutions, and they support when they're meeting with people who may be eligible for Medicare. They ask about that. We set up a process where they can actually, in that moment, check to see if that person is a patient that's in our ACO, and if they are, then they help them with and inform them of the ways they can actually get the additional in-kind benefits that Mr. Atala was just speaking of.
Thank you. I think that's my only question.
Hey, good morning. This is Tom, and thanks for being with us again this year. I know from the discussion earlier that it's difficult to segment out Vermont, but I'm wondering if you're meeting your savings targets as an overall ACO and in Vermont. I imagine you'd be interested in knowing that because Vermont's already a low Medicare state, so it may be harder to meet the targets. But could you comment on how you're doing with the savings targets, please?
Sure. So for 23, we were within our essentially minimum savings and minimum loss rate. And so we had our overall benchmark was 221 million, 221.7 million. Our expenditures were 222 million, 222.3 million. So like a 0.2% loss. And so from that end, we view that as neutral because it's statistically not relevant. So I think from our in terms of how we think about savings, what we really use is every quarter CMS provides us with quarterly benchmark updates. That again, that's at the overall level. So we tend to look at things just because we are operating in multiple states with one entity, which might be different for other partners. We tend to look at things at the overall ACO level. And then we do look at expenditures, and how expenditures themselves are trending. So how claims are coming in for Vermont specific beneficiaries. And so I think we don't necessarily look at Vermont's costs as low or high because it's really a relative question. So they're those patients, their costs are low now or wherever they are now relative to others in the country. Their benchmarks were also low. And so it's a question of, how does trend work in Vermont versus elsewhere? And those things are all accounted for in creating the target really for future years. And so I think, we let that play out. And I think from our end, our focus is how do we focus on, the things that we hope, align fully with the blueprint and the board. So we have some core quality measures. So diabetes, hypertension, depression screening and follow-up. I think Dr. Go ahead, sorry.
Yep, sorry, Mark. I want to ask about quality in a second, but
Sure.
and I appreciate the explanation, and I'm trying to get my head around it, but it's still not clear to me if you're meeting your savings targets.
Yeah, so our expenditures for 23, in terms of target, I think it's overall benchmark, right? I think is your question. Yeah. So right. So we did not meet CMS's projected benchmark of 221.7 million. Our expenditures were 222.3 million, which is again about a 0.2% delta. Because of that, our risk contract, we've chosen a 0.5% up and down savings and loss rate, which means that there's no dollars from us to CMS and no dollars from CMS to us in that band. And so this is our first year to see how, at the aggregate level, our target was going to be set. And, I think 23 was an interesting year for a number of reasons, but I think when we see a neutral result for us, for us, that means at least the benchmark is functioning as expected, as we'd hope. And
Yep.
so I think it allows us to really work from there to say, what are the things that we can do? But I'll hand it back to you for the quality questions or other follow-up.
No, thank you, Mark. It makes sense, right? Coming out of the pandemic, things getting back to normal. Now you have a benchmark that you can try to work with that's probably more accurate, more predictable going forward. So thank you for the explanation. I appreciate that detail and just the straightforwardness. Similarly with the quality, are you meeting your quality targets?
So I'll take that one. Thank you, Mr. Walsh. 2023 was the year where we actually were able to get the results to set our benchmark in terms of where we are. We reviewed that with the governing body of the ACO. They're very engaged in every organization taking that information and looking to their own clinical care processes on how they can improve. I'll give you one example. This is common across all our partners, but in the diabetes measure, 30% of patients the clinic did not have a record of the patient's hemoglobin A1C, which is a blood test that lets a person know in very general terms. The clinician in me, it says, I look at it and say it's not the greatest test in the world, but it does give you some sense. And so there was 30% of patients that just did not have that performed, or they did not have record of it. So that's the type of outreach now they're doing, to call those people, check in, see how they're doing, get them in for a visit, help them get in if they have trouble with that. And in that visit, they can then measure and then act on that measurement.
That's great. The 30% without a measure strikes me as high. I'm used to seeing.
Sorry, just one clarification. So that's either 30% either without a measure or they're above 9.
Okay.
I apologize. Yeah.
Got it.
Yeah. And
okay.
I was just in response to it seems as high. Having done this for a number of years, especially in the first year, you begin to have visibility into that. That's actually not a surprising number for me, and especially in our particular population where our clinical partners are caring for people across a broad swath of circumstances, homelessness. The reality is that they have a lot of really hard things going on in their lives, and for the individual to have the time and energy to even focus on that and prioritize that when they're just thinking about, where am I sleeping, what am I eating, what's the status of my job, do I have a job, etc. That's challenging. So I really have a lot of respect for the clinical outreach and work that our FQHC partners are doing.
Yeah.
I'm sorry, Mr. Roll.
No, please.
Just one clarification too, for context, I think you look at other ACOs. When we reported quality for the quality you see across the ACO over 23, what 23 required was essentially all patients, regardless of payer. So it's not a Medicare only a quality measure. And so one of our partners is a large academic center, and let's say patients are attributed to them through specialists. If those specialists aren't performing an A1C, but they're attributed, they won't, that won't be counted. And so, I think when we look at Vermont specific, we're better than that. And I think, we've shared that data. We're now really on a quarterly model with our partner in Vermont and other partners to really help build up quality throughout the year to say how are we doing it rather than a one-time result, after the year. So that just context-wise, what's being measured is changing a little bit in at least Medicare.
Yep. Well, first, I prefer Tom, so please call me Tom. And I appreciate the context. I understand the 30%, I think, is when I mentioned that seemed high, that was I'm used to seeing the proportion of patients with an A1C greater than 9. So now that that's included in there, that it makes perfect sense. What I didn't see in your submission and what I'm interested in with the savings and quality is the trend over time, right? And I know that you're just starting, but some of the quality measures that our staff shared with us, LOR was below the median above peers, median of peers. And I don't see that as good or bad this early in your involvement and with Vermont, but watching it over time would be very helpful to us.
Yeah.
And so when you come back, being able to share whether you're meeting savings targets, whether you're meeting quality targets, and where you're not, what are your plans to address those areas? That would be really helpful to me, and I think to us as a board going forward. So thank you for the context you provided and your answers, and that's all I have right now.
Thank you.
Thank you. We'll hold public comment till all 3 of the Medicare only ACOs have been completed, as that's what's noticed. So I don't think we have anything else from the board. Is there anything else from you, Mr. Atala or Bryce Eicher?
I think the only item, maybe worth something later. I think we want to understand budgetary impact if there's changes to overall number of ACOs and where lives are attributed in Vermont in 2025 or after 2025, and so specifically if OneCare exits, how that may impact essentially administrative costs or administrative percentages to other ACOs that operate. We probably not the right forum, but we want to at least flag it for understanding. That's something that we're interested in. Thanks, Chair.
Good question. No. Yeah, I think that's probably a discussion to have with staff offline. It may take a little bit of back and forth and consideration, but thank you for flagging it. Ms. Sawyer, did you have anything else?
No, I was just making myself available to say that we are working on that very issue on our end, try to sort it out ourselves.
Okay, thank you. And it looks like the Aledade team is here. Is that correct?
Yes, we are.
Yes, good morning.
Okay. Good morning. I am going to personally abstain from this overview and the vote on Aledade. And Member Walsh has kindly agreed to act as the acting chair for your hearing. And so I'm going to step aside and have Member Walsh lead this portion of today's hearing. And then we'll take a break after that, and I'll come back for the last ACO. So thank you, Member Walsh, for stepping in, and I'll be back after this. Thank you.
Great. Thank you and good morning. Michelle, did you have any introductory remarks before we shift to Aledade?
I do not.
Okay. Then please proceed with your presentation.
And what we'll do briefly is administer the oath to those who are going to be presenting. So if everybody from Aledade who's going to be speaking or maybe speaking could turn your cameras on.
I will be speaking.
If you have them, and then unmute yourselves and raise your right hands. What I'm going to do is I'm going to administer the oath for witnesses, And what I'll do is I'll read it. You can say I do, and then we'll proceed from there. Okay. Do you solemnly swear that the evidence you shall give relative to the cause now under consideration shall be the whole truth and nothing but the truth, so help you God?
I do.
Yes.
I do.
All right. You are sworn in, and I'll turn it over to Alidade for presentation.
Matt, are you going to pull up the slides or do you want me to just start talking?
Yeah,
Oh,
can you
perfect.
see them?
Yep,
Yes.
I can.
Okay.
And did you want to say anything, Matt, or did you want me just to go ahead?
Yeah, if you want to jump in, yeah, appreciate it.
Okay. Good morning, everyone. Krista Sperry. I am the market president here at Alidade for our New England market. I've been with the company for just about 3.5 years, so it's very nice to be presenting with you all this morning, and we are extremely excited about the opportunity to be bringing our New England ACO to the Vermont state. So Matt, if you don't mind moving along, this is just our motto: do more good for patients, society, life. And I think you skipped a slide for me, Matt. There we go. That's okay. you can go past that. That's just our motto. All right. So the ACO that we are bringing to the state of Vermont in 2025 is called our Alidade Accountable Care ACO 205. It is an MSSP enhanced track ACO. The first performance year for this ACO is currently happening. So 2024 is when this ACO started here at Alidade. It consists this year, you can see of the board compensation there of 13 members of our practices throughout 4 of the states this year in New England. So that's Massachusetts, New Hampshire, Connecticut, and Maine. In 2025, we are looking to add the Richford Health Center into this ACO in Vermont. And so we would have 5 of the 6 states in New England. There are no participants today, nor do we anticipate any in 2025 in Rhode Island. Any questions about the overall ACO? Otherwise, I'm going to let Elisa jump in and we'll skip to the next slide and discuss a little bit more about Alidade.
Good morning, everybody. I'm Melissa Collinson. I'm the National Director of Strategic Markets for Alidade, and we thought it might be helpful to get kind of an overall context about who Alidade is, what we do, how we operate a little bit, because it does apply to, we're a little bit regional specific as far as like regional needs and our and how we serve our partners, but our overall, we do have 44 in 2023, 44 ACOs across the country. So it might be helpful to kind of understand our ethos and how we work. This slide here is just to help you understand. We have a designation as a public benefit company, which is something that is legally embedded into our legal structure, which basically says that what Alidade does with our resources at the end of the day, how we invest them, has to be aligned with our mission, which, as Krista said, is to serve our practices, serving their patients, and then doing better for all of them, and that will be better for society overall. And we do that through the vehicle of preventative primary care in the MSSP program. So this is something we did that's fine, and Matt, you can stay here. It's something we did 2 years ago, and you can look up about it if you're more interested in it. But it basically makes us as close to a nonprofit as you can be with actually having the resources to be able to reinvest back into our ACOs and their communities that they serve. We do the work of MSSP through very specific actions. We call it the Core 4. But MSSP really is a long-term game of delivering really high-quality preventative primary care, which, as we know, the community health centers, we serve over currently 314 community health centers in the country, and they are doing this work. It's just helping them be more efficient and helping get even more close to real-time information to them, and then also supporting them with boots on the ground and a team to surround them clinically and operationally. Next slide. So this is a little bit about the teams that surround our partners. whether it's with small independent, one doctor primary care practices on very rural areas, or with larger multi-specialty groups. We provide you with a practice transformation specialist, local medical directors that really are engaging the clinical side of value-based care. And then a team of experts behind the scenes. We have incredible policy experts that work closely with federal, state, and local policies that impact the delivery of primary care. And then we also do a lot of analytics behind the scenes. We have about over 2,500 or more and growing practices with Aledade and TINs that we need to always be looking at to make sure that they are in the right ACOs to make sure they're getting the greatest outcomes that we can possibly deliver with them in partnership. We also have market presidents such as Krista Sperry. We have market leaders and teams of technology experts behind the scenes that are taking suggestions from our partners to improve the population health tool that we give them. Go ahead. So Aledade, as Krista mentioned, the 205 New England ACO is an enhanced tracked MSSP. And Aledade really only has our ACOs in either track E or enhanced. That is basically because our model of how we create shared savings is all about aligned incentives. We don't have any hidden fees. We don't have any charges for extra support that we do with a lot of our, in quotes, wraparound services that we give to our partners. We very much are transparent in how we do our split. We don't take any operational costs off the top before the shared savings split. We just purely split shared savings that is received to the ACO from CMS 50-50. So we are incentivized to, as I said in the beginning, put our resources into our ACOs to make sure that they're doing as best as possible and either in track E or enhanced. That we really try to move our practices in ACOs or whole ACOs sometimes at a time into enhanced as quickly as possible, because that is the one track where Medicare keeps 25% of the upside and the 75% comes back to the ACO. Go ahead. I mentioned the population health tool that we have. We call it the Aledade app. It's not really an app, but it's easier to say than population health tool. And we provide, as I said, everything free. We pay for all the integrations. We are pretty much EHR agnostic at this point. We work with over 120 different EHRs. And our teams are experts in the EHRs that we integrate with. It's usually about a 60 to 90 day implementation time period. We are constantly on 2-week sprints improving it by the suggestions of our users. We have an 88% use rate per day, which is, I think, shows that our practices and their support staff find it useful and are using it to get insightful information and helpful information. Here, I want to mention that it is a team-based tool. It is not only focused on just what's at point of care. There is one part of it called the daily huddle that is point of care that really provides information at the point of care, not only integrated and put together from the data within the clinic's four walls, but bringing in four feeds of claims, pharmacy, fill, hospital, and lab from outside, and specialty information, so that right all in one place in one screen, you can see all that information about the patient and speak to it directly. There's a lot of various workflows that really to support staff that just make their time more efficient. As you know, community health centers have a workforce shortage that they're struggling with, and providing efficiency to the work that they're doing is very important. Next slide, please. This is just another kind of visual of what the app focuses on, and its overall rating as well. It's very much used and appreciated by our tiny little practices and our very much larger ones as well. Next slide. So we also have very a focused point to deliver customized patient outreach services and also help engage the right patients at the right time. This is opt-in. You don't, it's clinics and practices do not have to participate in these. Most choose to opt in because it's very efficient for them, and most of them don't have the resources to do this themselves. So we do this for them. Examples being right now, we have Healthy for the Holidays that ramps up, which is to try to get patients in for their annual wellness visits before the holidays take over. And so we really focus really at the all throughout the year, but we do have this kind of ramped up focus towards the end of the year to get the patients in for their annual wellness visits. Next slide. This is just a list of some of the solutions and services and resources that we provide. I won't read them off to you, but we do have a part of Aledade, and this is again all at no cost. We have a part of Aledade, it's called Aledade Plus, that does, if it's appropriate and you choose to opt in for your patient populations. We have a comprehensive advanced care planning program. We have a kidney care management program if you have patients that need a specific focus on that. All sorts of other things that we look at and focus on. We're very data driven, so that clinical trials piece is interesting. I'm very interested in data driven decisions, and we look at that a lot. We do not ask our partner practices to do any extra focus on work. When I talked about the core four, we have looked at our data over 10 years in the MSSP program and seen the very specific things that drive shared savings and good patient outcomes. So we focus on the things that we know are providing value to the patients and then providing value back to our ACO partners as well. Next slide, please. So we joined early, and we heard you asking overall results as far as our ACOs versus other MSSP ACOs, and are we hitting target? So Aledade, as I mentioned, has 44 ACOs, and this is just to say this is 2022 data. We're updating the slide with 23 data right now, but currently, or in 2022, Aledade's, all of our Aledade cohort ACOs, so taking that in the MSSP program, we perform at, and this is measured by shared savings rate, an average across our Track E and enhanced ACOs of 10.4% is our average shared savings rate. And then other ACOs in the MSSP program, so all non-Aledade ACOs, their average is a 2.7% shared savings rate. Our quality scores overall also are higher than the average score. Again, this is 2022. To be transparent, in 2023, which the data that we just got, we were just slightly higher than the other average. And I think the average overall decreased in the MSSP program with quality. And I believe it's because of what Mark mentioned, is the kind of across all payers reporting, which is a little bit more complex and difficult to do across ACOs, which we do the quality reporting for our ACO partners. Next slide. And I will let my colleague Kevin take over from here.
Good morning. I'm Kevin Devlin. I'm the Senior Director of Finance here at Aledade. So currently what you're looking at is our projection for 2025 savings based on the Accountable Care, Aledade Accountable Care ACO 205. As Chris had mentioned earlier, this is majority of the practices that are in this ACO are beginning their second year. So we do have good data on potential targets for the benchmark. Since we will be entering PY2 of this ACO, that target benchmark is $13,605. We anticipate about a 4% savings versus that benchmark for the entire ACO next year, for savings just over $2 million. That savings is essentially based off of the estimated tailwind that we are projecting for when Vermont comes into this ACO, utilizing their historical expenditures and aggregating and estimating based off of the current ACO's performance. generally year 1 and 2 ACOs see improvement around 2.5% from the targeted tailwind. So that's how we are calculating to that, but just under 4% for this ACO for 2025, which would be just slightly up from what the ACO is experiencing this year in 2024 based off that estimation by about 50 basis points.
And so that summarizes our formal presentation. I think we'll take any questions.
Thank you very much. Open it up for board questions.
I don't have any questions at this time.
I have a couple questions. Just got to get myself a little organized here. So on page 10 of your submission, in answer at the end of section 3, you had talked about ACOs that report quality data can meet quality performance standard through one of 3 pathways: achieving a health equity adjusted quality performance score. And then you spoke about the 3 electronic clinical quality measures. But I didn't see the 3rd pathway. So I wonder if you could just clarify that. And if you'd rather take that back and clarify with staff later, that's totally fine. Just wanted to make sure I understood your submission.
I think so we owe the staff a few follow-up questions next week, and we can take this one back.
Thank you. Appreciate it. Okay. And you did answer one of my questions. I was curious to learn more about the opt-in to the additional services that you mentioned. Why would you say that a practice would or wouldn't want to opt into the additional services that you offer?
Yeah, I can speak to that, and Krista jump in too if you feel like it. So sometimes there's, like, for instance, comprehensive advanced care planning is a sensitive topic, and we work with very small physician practices that have very close relationships to their patients, and they may feel that they don't want Alade's team, who they focus purely on the comprehensive advanced care planning, and having a social worker, a lawyer, all of the family members present is about a 2-week process. But there's some practices that feel like I would rather keep that conversation with myself and my patient and not have Alade's team do that. So same for, comprehensive advanced, kidney, the CKD stuff that we do. There's just some doctors that feel like I have a better relationship and close with my patient. And even though we work on soft handoffs and all of that, we want to leave that choice to the practice. We don't want to dictate how they do their patient work.
Yeah, and I would just add overall, and Elisa's absolutely right. We're not a one size fits all. We kind of meet our practices where they are. And overall, some practices are staffed much differently than other practices. So we have some practices that utilize all our services just because of staffing issues, or some practices go through periods of time where they might lose an excessive amount of staff and can't keep up with some of the back office kind of activities that help them be successful in value-based care. So we're here to support them in those times when they need extra help.
Thank you. That's really helpful. I'm wondering if you were familiar with Vermont's Blueprint for Health program, which is our statewide advanced practice, medical home, and community health team structure. Because one of the questions that I have about your model, particularly with the wraparound services, is whether they are duplicative of or supplemental to the blueprint, and how to ensure that your work supporting the practice and what's already happening in the community with the state community health team, and make sure that that's all working together and not at cross purposes. So If you are familiar with the blueprint and have any thoughts on how your model meshes or doesn't mesh with it, that would be helpful. And if not, then I guess I would simply ask if you'd be willing to take the blueprint for health orientation so that we can ensure that your care model doesn't conflict with the state's care model, which is a requirement in our regulatory process.
So I'm familiar with it just from, learning Vermont and learning it. I will say, I think all of us would like to do that. Our clinical medical director in New England lives in New Hampshire and has worked there for many, many years. I'm sure she's been more familiar with it. But for myself, I'm definitely willing, and I'm sure our teams would be willing. I will say one of the first things that we do when a practice signs with us is get to know the practice for those very reasons, because we don't want to be duplicative of things that are working. We want to help them find the areas where there's opportunity to improve and provide support in those areas. It doesn't make sense to kind of reinvent the wheel.
Great, that's great to hear. I think I have a couple more questions. So in your submission, you talk about high value referral management. Could you explain what you mean by high value referral management? It's on page 15, if that's helpful.
Krista, I'll let you take that one.
I don't know if I'm the right person to take it. I might ask Matt if that's one of the follow-up questions that we're supposed to be.
And it's totally fine. Again, anything, happy to have you follow up if that's easier.
I'm trying to pull up the page quickly so I can just read it. So
Yeah, one moment. I'm trying to locate the.
It's on page 15 under the paragraph that is the first paragraph of care management. We use data to help patients get the best care that complements the care they receive from their PCP. This includes high value referral management as well as comprehensive advanced care planning. I think I understand what referral might be, but I'm not sure what would make a particular referral more or less high value. So that's what I was interested in learning, is how you understand that.
I think these are overall Aledade general statements. I think for New England, Krista, as an ACO matures, they might move into more of that, but I don't know if Krista's ACO is doing that currently.
yeah, we don't do referral management today in the New England ACO. I think to Elisa's point, we have piloted in other parts of the country. And maybe that's where it was high value. I don't know exactly how that was termed or why they termed it that way, but I'm thinking it's maybe directed towards something like that. But we can definitely follow up on that as well and just confirm.
We did have an area of the app. We actually took it down recently, but it was about like basically the clinicians could go in and type up a specialty and find across various different sources how specialists were performing in their area and where they're located, and not just performing as far as like outcomes, which are of course are important, but also looking at like total cost of care and those sorts of things. And we do not have that currently live in the app anymore.
Okay, thank you. I just had one more question. So in terms of your focus on health equity, I'm certainly the focus on racial equity as part of health equity is very important. It's an area in Vermont where obviously as a mostly white state, we have certainly things to improve. But in Vermont, we've also been looking at health equity a little more broadly, trying to look at rurality or like the social needs index, socioeconomic issues, those sorts of things. So I was just curious to hear about your definition of health equity and whether you tailor that to different locations or sort of how you think about that.
Yes, we have to. We have a health equity team, and we do have to tailor it and come to very specific areas. For instance, our Mississippi ACO, very populations that have huge access issues and are in food deserts, et cetera, all the things that can impact rural areas, and it's one of our highest performing ACOs. So we are very proud of the work that we do with the social needs of the populations. We really tailor it to the specific areas. Like for instance, if it's an access issue, we in some areas where Uber is available, so not rural, but we partnered with Uber to get patients to the physicians. In some areas, it's helping them with creating clinical food pantries so that patients can access specific nutrition for their specific chronic diseases.
Thank you very much. That's all my questions. Nice to meet you all.
Nice to meet you.
Thank you. I just have a couple questions also. One, I appreciate it. I appreciate you addressing savings and quality in your presentation. On slide 12, you had a graph about savings targets. And I'm wondering if you could pull that back up.
One moment.
Yeah, sure. Take your time. And this is mostly just to help educate me personally. Could you help me understand how I should interpret the 10.4 versus 2.7?
Yeah. So that's shared savings rate. So the rate at which you are creating shared savings. In the slide that Kevin went over, which is I think the one after this, where the MSR, that's a minimum shared savings rate. So for this ACO 205, it's an enhanced ACO, and in the enhanced track with MSSP, you are allowed to choose your minimum shared savings rate. Some ACOs in Track E, you cannot choose it, and it gets set by Medicare. So let's say it's a 2% MSR. If your shared savings rate is 1.9, even if you're in Track E where there's downside and upside, Medicare keeps all of that, doesn't give you any of it back. You have to get over that ceiling that's been set. We set 205 for 2024 in the contract period of this ACO, this first contract period, at 0% because our actuarial team behind the scenes looking at projections felt very confident that this ACO would be able to create shared savings. And because we get a choice, it's nice to be able to keep 100% of whatever you do create, even if it were to be just 2 or 3%, although this is, projections, but I'm supposed to be a little higher than that. So essentially, when we talk about shared savings rate, our in 2023 performance, Alade's average shared savings rate for our enhanced was significantly higher than this too. So we have some very high performing enhanced ACOs across the country.
And I just want to add one thing to that. So just on that graph, so you can see the years. This is a cohort view of that graph. Mm-hmm. So those are our ACOs that have been with us for a year. So when you see the Y6, year 6, so our ACOs that have been in with us for 6 years are averaging 10% savings.
Yeah.
And so, that's the trend that we are going on.
Yeah, and if you think of it translated in 2023, so not cohort view, just purely 2023 results, our earned savings average across Track E and enhanced ACOs, if you think of it a per member per year dollar amount back to our partners, so after Alade's split was 549 PMPY. Sorry, that was to the ACO before the split, and then versus the non-Alade ACOs, which is 275 before any sort of split, which we don't have visibility into, obviously, because that's ACO to partner contract.
Yep. And so that was, I don't remember the exact figure, but 500 per member per month?
Year, so 549. So if you have 1,000, think of the ACO. If the ACO has 1,000, which is obviously the minimum is 5,000, that's not true, but just for math's sake, it would be, 54,900 back to the ACO. So if the ACO has 30,000, times it by that, back to the ACO.
Great. I appreciate that. That helps a lot. You also mentioned that you're routinely meeting quality targets. In my experience, oftentimes with quality targets, you'll be meeting some, but not all. And so I'm wondering if you could tell us a little bit about how you choose to focus your quality efforts, what your process is like. Not giving away any trade secrets, just helping us. You are a large and experienced group of ACOs. I'm trying to learn from what you've done. So how do you have a process for that? How do you determine your objectives and key performance indicators, those types of things? Could you share a little bit of that with us, please?
Sure, I can do overall, and then Krista can jump in specifically to 205. So we have a quality team that, and all the data. And while this Vermont is just participating, the notch is just participating in our MSSP ACO, we have other payer downside risk arrangements. So we do this quality across all of our payers. But for MSSP specifically, we have never, I don't believe, ever had money withheld for not missing quality targets. So we do overall always hit that ceiling and get over it with the quality. For specific measures and everything, I know Krista's team operationally meets with the partners regularly, showing them and tracking quality results. And I'll let Krista speak directly to that. You're on mute, Krista. You're on mute.
She is having trouble. She just messaged that she.
Oh, sorry. Okay. So Krista has an operational team. I'll shoot from the hip a little bit because I used to be the executive director of New England. So she has a team that supports her that is, we get our data from CMS and we track the quality measures with our partners. We have a clinical team and we have the operational team. The clinical teams meet once or twice a month, depending on how long they've been with us and how routine everything is. And we make sure that they're on target. And we have different initiatives that if we see halfway through the year that we're low in certain areas, we can either provide support, like she said, if they need it and they don't have the workforce to do outreach to get patients in to look at specific measures and help close those gaps. Or we can, have some education. Sometimes it's just purely education that needs to happen around how documentation happens and how processes are occurring within our partners, and we can support them on that. So we really do track very closely in all of the meetings, measuring quality and also measuring other important measures to drive shared savings.
Thank you. I don't have any further questions, and I think we're holding questions from the healthcare advocate and from the public until all of the presentations. And so what I'd like to do right now is take a 10-minute break and let Chair Foster know that it's fine to return, and we'll resume with him in charge at 10:33. Thank you very much.
Thank you.
Off the record.
Hi, Aaron. I'm just checking my audio again.
Okay, sure.
Okay, I think we can go back on the record. And we will next have the budget review hearing for Vitalize KS. And I'll turn it to, actually first, Mr. Hengsler, if you could swear in the witnesses, and then we'll have Michelle Sawyer provide any overview she may have, and then we'll turn to the Vitalize team.
All right, good morning, everyone. If the folks from Vitalize could go ahead and turn your cameras on and unmute yourselves. I'm going to administer the oath for witnesses, and I'll ask you to raise your right hand. Do you solemnly swear that the evidence you shall give relative to the cause now under consideration shall be the whole truth and nothing but the truth, so help you God?
I do.
I do.
Thank you. You are sworn in.
Ms. Sawyer, do you have any
There's nothing-
overview, or do you like to? Okay, great.
Nope, we can hand it right over to Vitalize.
Great. All right. Well, thank you all for being here, and we look forward to hearing from you today.
Thank you for having us.
Do you all have a presentation or any information you want to provide, or just board questions?
Yeah, I think we have a few slides. Do you guys have the slides, or should we share our screen?
I think if you can share your screen, that would be great. I'm sure we can manage it if you do not.
1 second, let me load it up. Apologize, I thought slides were with you guys.
No problem.
All right. You guys able to see my slide deck?
We can. Perfect. Thank you.
Perfect. Thank you, guys. Sorry about that. Hey, everyone. My name is Amir Al-Najjar, internist by training, one of the co-founders and chief medical officer here at Vitalize Health. And once again, thank you for giving us the opportunity to be here today. Want to talk about Vitalize and our ACO entity KS that we would like to operate in Vermont. So a little bit of a background about Vitalize Health. We view ourselves as a provider enablement company, so we work closely with primary care physicians in order to help drive them from fee-for-service to value-based care. We lead with data-driven, holistic approaches with our practices. We also bring in an all-in-one solution that includes upfront incentives for practices to do value-based care items that may not always get reimbursed by Medicare. So we try to bring additional funding to practices and resources, clinical resources as well, to help improve the care delivery model, across their Medicare beneficiaries and their practices. A lot of the incentives that we pay for, they're bread and butter value-based care items like transition to care, annual wellness visits, making sure quality metrics are met. We also have a clinical evidence guideline base where we call it Vital Insights, where if we see patients having gaps in, certain medications for their conditions that have been proven by evidence to be beneficial, we'll flag these items for the PCPs to take under consideration. Next slide. Okay, so
what is our goal? As I said, our goal is to help the transition of value-based care by taking care of the docs that take care of us. We really believe that by helping with a lot of the administrative things that many PCP practices deal with, we are able to give them more time back to focus on the patients. And that's exactly how we would love it to be, where they're focused on patients and not having to deal with the administrative logistics in healthcare. We're also able to bring certain things to them that they may not normally have, like ADT feeds, letting them know when their patients have hit in hospital or been discharged. And most importantly, just additional clinical resources, nurses, RNs, pharmacists to help outreach to patients that may benefit from it. So we really try to take a holistic approach with our primary care providers by ultimately not replacing or doing anything they're doing, but just supporting them, and areas that they raise their hand up and ask for help, we're able to deploy resources there to make sure that gets done.
Can I interject, Amir? I'm Brian
Yes,
Opes.
please.
I'm one of the ACO medical directors. I'm actually the doc that meets with the practices both in person and virtually, and work with them, the office managers, some ancillary staff. And we really do, I think, a great job of providing not only services, but helping them with what they're already good at, and more importantly, what they're not good at. Every practice has something that they're very well tuned on. We try not to mess with that, but every practice, particularly some of the health centers, have some very special needs, and that's where we really try to interject and tailor the experience to those particular practices. We look for efficiencies, particularly in their processes. We find a lot that their processes sometimes are inefficient, or in some cases don't even exist for particular initiatives. So we help the practices develop those types of things. And we, kind of like Amir mentioned, we do provide data to the practices. And I recognize in particular that they have very limited time to spend with us. They're very busy folks trying to keep up with the patient flow. So we try to make that data actionable and very specific. I mean, you could literally drown somebody in data, but that doesn't do anybody any good. So we try and provide little bits and chunks that are digestible and manageable. We find that you'll get actually a much higher buy-in from the providers and office staff if we're able to do that in small pieces. Amir touched on this as well. I think so far, one of the shining pieces that we've been able to provide for these folks is an idea of where their patients are. And in particular, I'm talking about in-hospital stays, both in Vermont, surrounding states, as well as for the snowbirds that are down in Arizona and Florida. A lot of our providers that I've been working with have said that I don't know where these people are because some of our hospitals are not, or either we're not connected to them through either case management, social work, some sort of direct feed. So it's been really valuable to a lot of our practice partners to know where their patients are actually going, because it's very difficult to follow up on somebody if you don't even know that they were in the hospital. Amir kind of touched on this as well. We have a program that will be available to everybody in 2025. It's actually available now. It's called Vital Care. A lot of our practices, I'm sure you're all aware of this, are very understaffed and stretched very, very thin. So Vitalize now has the ability to reach out to these practices and help with some of the patient outreach. We're able to actually, if their patient gets discharged from the hospital, we're able to reach out to this patient for them, touch base with them, make sure they have an appointment for follow-up. And it's really offloading a lot of the burden from the practices onto Vitalize. And that is a no-cost service to the patient or the practice. Part of that Vital Care program is additional services as well. We can look at social determinants of health. We have a nutritionist available. We have a pharmacist available. We have access to social work. And then if your patient says, if they say, oh, I ended up in the hospital because I couldn't get a ride to my pulmonologist and I ended up in a bad COPD exacerbation, we can work with local resources in the area and try and get them, rides to try and keep their care consistent so they don't end up in the emergency room or the hospital. And as far as utilization, we have some access to some pretty sophisticated type things. A lot of what I spend my time with is working with the practices, letting them know which of their attributed patients are high ER utilizers. And now we have the ability to even look down to diagnosis that are going frequently. There are some things that are considered perhaps potentially avoidable that could have been caught in the office, but they ended up in the emergency room. We have analytic ability to tell them what day of the week is now their highest ER utilization day. I've recently worked with a practice that I was able to show them they had a chest pain issue, and we were able to get down to the point of who those patients were, what days of the week they were going, and allow them to kind of look at their own internal system to say, okay, great, perhaps I need extended hours on such and such day to help address this because I have a huge ER problem on Mondays. And it also allows them to know kind of where they should develop their resources. If ER diversion is a key piece, they can devote like available mental and financial and capital resources to try and reach these patients sooner to try and prevent them from going, because not everybody in Vermont is going to have an urgent care next to them, or something. You may have only one hospital choice. And then we also look at performance. Every practice has, multiple providers. Every provider has different performance levels, and we're able to tell to the practice exactly provider A versus B, how they are looking as far as here's your follow-up rates for this particular provider, here's their readmission rates. This is how this provider does on recapturing HCC coding for Medicare risk adjustment. And then at times I've gone up to Vermont and I've had like lunch and learn type things where I was able to talk with the providers, say, this is what's changed in the world of coding. These are the things you need to know. And in some cases, we're able to do targeted, if you have one particular provider, we're able to do targeted education to try and bring that provider up to speed. Because, they don't really teach value-based care in residency or medical school. So sometimes it's a lot of the newer folks who are coming in that we have to kind of bring up to speed. We really try and tailor that to what they need, and not really force something down their throat that they're already good at. And I really try and not waste anybody's time, because I understand that getting behind in clinic is a nightmare. So we try and make it as as basically as efficient as humanly possible.
Thank you, Brian. Appreciate that color. So this is the information regarding the ACO. It's going to be our first performance year for this ACO in 25. It's going to be a MSSP level E basic track. The ACO size is roughly 26,000 lives. 1,600 of them are affiliated in the two practices in the state of Vermont. Little Rivers and Mountain Community Health are two practices we're working with in Vermont. Next, let's see. Okay, so that's all we have in terms of slides. The next part is the budget financial. Should we hold on to sharing that for the private session, or?
Mr. Henksler, has that been granted confidentiality by the board?
Yeah, so two pieces to this. The first is that Vitalize submitted some materials that were granted confidential treatment, included some of those materials in one slide that it submitted to us. If the slide, correct me if I'm wrong, Vitalize, but I believe that slide contains nothing new or different from the budget submission. It just contains information that was treated confidential in the budget submission. If the board wishes to discuss those few materials with Vitalize, we can go into executive session. If the board would prefer to ask questions that it has and wait on whether or not we want to, we can do that too. So it's nothing that you don't already have in front of you is the thing that I wanted to share.
Great, thank you. So we'll proceed with staff and board questions, and if there's a need to go into an executive session, we'll take that up if it comes up. So first, I'll turn to Ms. Sawyer for any staff questions there may be.
Sure, just one question from us. So we had required folks as part of Vitalized Health 9 ACO, their FY24 budget order. There was a condition that some staff attend Vermont Blueprint for Health orientation, and I believe that was done, which is great because the Blueprint for Health is a really important program throughout the state. And we did ask a question in the budget guidance of this Vitalize ACO about how collaboration would work. And it was my perception that perhaps the folks who had answered that question in the budget guidance weren't the same folks that attended the orientation. So I was wondering if you all from Vitalize would think that perhaps it would be beneficial for someone from this current Vitalize ACO to attend the Blueprint for Health orientation. And I just wanted to verify that it wouldn't be duplicative of whoever attended for Vitalize this current year.
I attended last year. And
Great.
This is yeah, thank you. And this is still the my medical unit for 2025 for consistency's sake. So it would still be me.
Okay, thank you very much. That was my only question.
Sure.
I'll open it to the board for questions.
I can go ahead and go first. Hi, everyone. Nice to see you. So in your submission on page 11, you talked about, and today you've also talked about as part of your care coordination activities, you partner with community folks where that makes sense. So I'm just a little bit curious about, and it sounds like, Brian, you've had some experience in Vermont with the prior version of Vitalize. So if you could talk a little bit about what community partners you're familiar with and how you might have worked with them in the past or would expect to work with them in the future.
Yeah, I mean, I do have to apologize. I'm one step away from that. That is a separate team. Once we identify that patient X needs, perhaps needs nutrition, help paying their bills, types of thing, we have a separate team that will take that from there. And I understand that team incorporates as many local resources as humanly possible. A lot of stuff we can do in-house, but obviously we don't have Vitalized staff on the ground in every county in Vermont. So that team goes out and kind of figures out what resources are available in that particular area and tries to address it from there. I understand it's been very well received. I don't believe we've had a significant need quite yet in Vermont for this. It's the current attribution for last year was, probably around 2,000 lives. So I expect as the entity for 2025 is different, much larger, that would be a much bigger need. And that department is growing quickly. So we're throwing a lot of resources at it because we recognize that social determinants of health is becoming a very large issue.
Okay, thank you very much. So you spoke a little bit about this today, but in your submission on page 14, when you talk about providing actionable data and workflow optimization support, but in your submission, a lot of the focus was on the annual wellness visits. So could you give us a little bit more information about the types of actionable data you provide in addition to support around the annual wellness visits?
Yeah, I can take that. I could take that, Brian. So the annual wellness visit is a visit. It's like we view it as a vehicle to get patients in to be checked on by their primary care providers yearly to, uncover things. But, so that's sort of first step is getting the patient in the door to be proactively seen. But then, well, what does this patient need? By getting all the claims data, we're beginning to work to ingest EMR data. We're able to bounce them. We've developed a clinical content library where we're able to see, okay, we know, research shown if you're, a CHF patient, you should be on a beta blocker. You should be on potentially other medications. So what we see is whenever there's deficiencies or gaps, when the patient arrives, in their workflow in their EMR, we're able to tee up action items. We call them our vital insights, which are, hey, Ms. Smith has CHF. You might want to consider a beta blocker. Ultimately, it's the provider's choice. There may be a reason they're not on a beta blocker, but sometimes it's just gaps and people forget and things slip through the cracks. So we're able to resurface them. So we view as the annual wellness visit, the transition of care visit. We view these as the first step, which is the vehicle to get the patient in, but ultimately, things need to also improve during that visit as well.
And to add on what Amir said, for Little Rivers in particular, I recall they did not really know how to bill properly for an AWV because a federally qualified health center is a little different than the non-health center crowd. So we worked with them to be able to do that efficiently. And they had some difficulty. They didn't really have like an AWV template. So we worked with them to get the health risk assessment together, those kinds of things, got them all the pieces that they need so that they were trying to build that into their EMR to make it efficient. And that's pretty common amongst the health center crowd.
Great, thank you. So it sounds like the Vital Insights tool provides almost like a checklist for the provider to say, oh yeah, did that. Oh yeah, I forgot about that. Maybe I should talk to the patient, that kind of thing. That sounds.
Yeah,
and sound about right.
Yeah, exactly. Yeah, and that's based off the latest clinical research. So the society accepted guidelines, which some of the providers, if they've been around for a while, may not have kept up with the most current evidence-based medicine. So it kind of helps in that regard too.
Perfect. Okay, thank you. I think the other questions that I had are actually in the confidential section. So depending on what other folks have, if others have questions related to that section, maybe I can ask those in executive session, but if not, also maybe we could just have the staff follow up as the more expeditious way to do that.
Sorry, I had a little challenge coming off of mute earlier, but I just have two quick questions, which one of them kind of follows up on one of Robin's questions. But Brian, you mentioned digestible chunks of information to providers and gave an example of patients being admitted to the hospital or recently discharged. I guess I had sort of two questions related to that. One is how do you know, and at what sort of temporal, how quickly do you know a patient is admitted to a hospital that's not affiliated with a Vitalize organization or the practice that you're working with?
We have, Amir, correct me if I'm wrong, it's a 5-vendor, maybe 6-vendor national ADT system that we work with.
Yeah,
very
so
common ones like, yeah.
There are vendors like Patient Ping, Experian. We also connect with our HIEs in different states. But in order to get all the hospitals covered, it's a hodgepodge of vendors. I think we're at 6-7 vendors, and that's giving us around 68-70% of all the ADTs. And we're going to add another 5 vendors to get us to 80%. So it's real time to your question. It's usually a couple hours delayed. So it's same day. You're not finding out a week later that your patient hit the ER. And the number one thing is for providers to know that where their patients are, but also to help tee up the transitions of care. Everyone knows transitions of care are a beneficial thing, but they only happen 44% of the time in many of our first-year practices. And the reason is they don't know where their patients are. Patients are not good communicators. So we bring these systems, so awareness. And, as Brian had also mentioned, we also have clinical team members that are able to support patient outreach if the practice is short-staffed from an outreach perspective. But it goes to this notion of proactive versus reactive scheduling. Historically, most practices, whoever calls in, they give an appointment, their schedules are full, everything is great. Our goal is, it's not just who's calling in and who's needing you, it's also people that may not be reaching out that really do need you desperately.
That makes a lot of sense. I didn't realize that those data were available in such expeditious timeframes. That must be super helpful.
Yeah, it's just a hodgepodge of them because, one vendor will only cover you 8%, another vendor 12%. You got to sort of add them all up to get to 80%.
Yep. The other question I had was, what other, can you give examples of a few of those other clinical or chunks of information that would help someone's clinical practice?
Yeah, sure.
Yeah, go ahead, Brian.
For the two practices that we're currently working with up there, a large portion of it is coding. We're able to say, and my big passion is I want you to get credit for the work that you're doing. And I really hate these practices leave their efforts on the table in the eyes of CMS. So we can say, here's your patient panel. Here are your, let's say, top 50 patients that have the most outstanding codes from one year to the next. Are these codes still true? Some of them, sometimes they're not, sometimes they are. So we're bringing the idea of, I didn't code for this year to the practices. And they found that incredibly helpful because depending on their EMR, some EMRs are really good at telling you Mrs. Smith had diabetes with complications last year. Does she still have it this year? Some of them are not. So they're able to use these tools to try and grab as many codes so they're getting accurate. It's because they want to show CMS their disease burden in Vermont. And if they don't code for it, because unfortunately every year.
Here, Brian, so part of it is coding, and a lot of these codes help inform us which patients have which disease burden in order to tackle them for the right clinical program, and making sure that our content library is, teeing up the right action items. But to your example of like actual clinical items, if a provider, for example, doesn't have a patient with COPD on an optimized treatment, two dual inhalers, and they may be on one inhaler, because back in the 80s and prior, therapy was one inhaler. So it would flag that this patient is only on one inhaler, and it would tee up to suggest to consider this additional inhaler. There'll be a link to the article from the Journal of Medicine, from the different guidelines to sort of, if the provider wants to see, well, why should I do another inhaler? They'll have the research and the clinical guidelines right then and there. So, a lot of it is, like the way I think about our clinical guidance, step one is, which patients do you need to be worried about and be bringing in? Who had a discharge? Who's a high cost sick patient that you haven't seen in 9 months, maybe because they haven't been reaching out? So we try to bring these patients in. And once the patients are in the exam room, we then tee up gaps. They may need a colonoscopy. They may need a mammogram. They may benefit from a medication being added, or a medication in some cases being prescribed. Maybe they're dementia patient on a benzo. And so in these items, we just started it in 24, but we've had a positive ROI. Providers are accepting it, and there's a lot of provider interest because it's actually shaping the care of their patients.
Great,
another piece. I'm sorry. Another piece, David, is practices have found really good value in, and like, can you tell me who's due for an annual wellness visit in the next 30 days? Because it is kind of cumbersome to try and figure that out. So we're able to tell the practices, these are the patients that are due in the next 30 or 60 days. And they found that very helpful to plan their schedules going forward. So that's been a very positive piece as well.
Can I channel my board member, Tom Walsh, here and say, can you tell a provider how many patients with a hemoglobin of A1C greater than 9 have not been seen in the last 3 months or 6 months, or a period of time, of who should be seen?
We're working on that. So we're beginning to get the data from LabCorp and Quest and the big lab vendors. And that's because that's hemoglobin A1C results are not on a claim typically, and so it's either from EMR data or from the lab data. And where, that's been the focus in 24 and early 25, is getting that actual non-claims data. And that would enable us. And that's exactly the ACO quality metric of, is your hemoglobin A1C above or below 9?
Great. Thank you so much.
Thank you for the presentation. Similar to the questions I've asked the earlier presenters, is Vitalize meeting its savings targets across your locations?
our savings targets. So in, obviously we would always like our savings targets to be higher. In 23 and 24, we've had, tremendous growth across many markets, and that's hampered some of our savings numbers. We're still generating savings, and in 23 we saved CMS $25+ million in savings across our programs. We are trying, we're obviously we're ambitious and we want to do better, but one of the reasons that's been challenging is due to growth, and we've slowed down growth. 24 to 25, we did not really grow. We just working on maturing with our practices and making sure our practices are doing all the right things. But that's one of the limitations in value-based care is, the more people you add that don't know what they're doing, it takes time to know what they're doing. It hurts the group. So we're trying to be mindful of moderating growth. But yeah, 23, 24, we generated savings, not as much as we would like, simply due to tremendous growth. But that won't be the case in 25.
Yeah, there's a lag, right?
Yeah, we just found out
comes on.
23 results in October.
Yep. Okay.
And 24 results we'll find out in October of 25.
Great. And with quality, are there quality measures? Are there quality challenges that you've seen in Vermont that are, what quality challenges have you seen in Vermont?
Brian, you want to take that?
Yeah, so in the eyes of Medicare, the model that was in place currently for 2020, where we at 2024, is the REACH model. Their quality measures are slightly different than what we're going to be in 2025, because we're going to go to MSSP, which has MSSP is very similar to what Little Rivers and Mountain Community Health are used to through their UDS reporting. Breast cancer screening, colon cancer screening, those kinds of things. The quality issues we've seen in 24 are more around like utilization, hospital visits, those kinds of things. The biggest issue I've probably seen is ER follow-up for certain disease states. I think likely due to capacity issues.
CMS is grading us on a quality from a mixture of claims and actual reporting. So they're looking at how often are our docs following up post-hospitalization, how often are our patients being readmitted to the hospital, how often are our patients being admitted, and then there's also, the hemoglobin A1Cs, the mammograms, colonoscopies. So it's like multifaceted what they look at.
Yeah. All right, that's helpful. Thank you.
Thank you all. Ms. Sawyer, anything else from you?
No, nothing from me, Chair Foster. Thank you.
Great. Well, thank you all for attending. We appreciate the presentation today, and I believe next week we'll have a staff overview and potential votes. So thank you for coming. I'm going to take public comment on all of the ACOs we reviewed this morning. You're welcome to stay, and you're welcome to leave if you prefer. Actually, I'm sorry, I missed the healthcare advocate today.
No problem. Nothing from us, Chair Foster, at least at this point. Thank you.
Thank you. Sorry about that, Sam. And with that, I'll open it up to public comment via the raise the hand function. Right. Seeing none, thank you everyone for attending and for the presentations, and it's nice to see everyone. We will take a break until 1 o'clock, and then this afternoon we have the OneCare budget review. So thank you. We'll take a break and go off the record till 1 o'clock.
Thank you.
Thank you.
Off the record.
Thank you, everybody.